Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I am Marvin Goldfried, together with my good friend and colleague,
Alan Francis. Good morning.
Alan. Thank you, Alan. Sorry, I stepped on your lines. I didn't realize.
You can step on me anytime you like, Marvin.
I won't go there. Anyway, listen. So let's talk today about therapist frustration with patients and how they can change that into compassion. Big leap. Maybe we can start off with the what is the dreaded C word within CBT circles? You know the dreaded C word?
No.
Countertransference.
Oh, yeah, okay.
I'll tell you what my understanding is of countertransference. You tell me what yours is, okay?
Do you want me to go first?
No, you go first. Tell me.
Yeah, first of all, I want to say I'm so glad you brought up this topic. I know you wrote a book, a wonderful book on this, and it's, I think, one of the most important topics in the whole field and one of the least discussed. I think that therapists around the world understandably feel frustration towards patients and often respond very poorly because they're not aware of it and don't understand it very well. I think that there are two different aspects to countertransference. The official meaning of it is that the therapist, like the patient, has had past experiences which very much influence their current perceptions, feelings, and thoughts and relationships. And that just as the patient may have distortions based on the patient's past, the therapist may have distortions about the patient based on his or her past. So that's one definition. A second definition of countertransference has to do with the fact that your feelings towards the patient may be a very valuable guide to understanding how other people respond to the patient. So that in effect, the first definition would say that countertransference is a kind of sickness the therapist brings to the treatment. It's a bad thing. The second way of looking at it sees it in a positive light, that if you can understand your feelings toward the patient, most of them are likely not to come from your own childhood, but if you're a healthy person, to come from the fact that you're responding to the patient, other people, in the way other people will.
So, Alan, if I say to you, I'm very glad you brought up that second point. It made me feel good. That's the second good countertransference?
Yeah.
Yeah. No, that's very good. And that is kind of a black hole in CBT. I think it's been a major limitation of CBT. And when I've taught and supervised graduate students, I make it very, very clear that you've got to pay attention to what's going on in the room, in the relationship. But let's talk about the first part, the negative part.
Before that, let me do one other thing though, because there's also a distortion of the understanding of countertransference that we've discussed once before, but just let me get it out there quickly. Namely, a lot of times the therapist is doing things with the patient that are obnoxious, and the patient gets angry about this, and the therapist then thinks the problem's with the patient rather than realizing that it's the first type where it's the therapist's problem.
Can you give me an example of that?
Yeah, well, one of the most famous analysts ever, I won't name him, was a pretty obnoxious person. And he would say and do things with patients that were, I thought, outrageous.
I see what you're saying.
The patient would get angry.
Yeah.
And the therapist would say, aha, you have a transference to me that's based on your past.
Yeah.
Not realizing that he was provoking this. And so people who are unaware of their countertransferences, unaware of their feelings about patients, will be unaware of the fact that the patient's feelings towards them may be realistic, not always.
Right. Kind of an unconscious countertransference.
Yeah.
Well, that's why I don't like the term countertransference or unconscious, because it's tied too much to theory. And as you well know, by this point, I'm not necessarily a big fan of theory, because it creates distortion. But I'm not going to go there now. So, but I want to talk about negative feelings, because as you correctly point out, this can totally sabotage the efficacy and effectiveness of therapy. And I think we can talk about it without using theoretical jargon, so that it could be heard and used and benefited by those who don't necessarily like psychoanalytic terminology. Let me start with some research. It's been found that when a therapist verbalizes something negative toward a patient, the patient gets worse. And this was done at Hans Strupp's lab, and the person who did the research was Henry. And he observed sessions, listened to sessions, and saw sessions, and it was coded for the degree to which there was a positive or negative communication from the therapist. And some of these communications, the negative communication, could be subtle. Therapists rarely curse and yell at patients, although some may. It's usually communicated in a more subtle way, like, why do you think that's the case with me? So there could be a tone of voice, and that could resonate with some patients because they've got radar built up from historical, early learning experiences, and they pick up on that and take it as criticism. This, of course, as we both well know, has been championed this issue has been championed by Marshall Linehan and DBT, working with people who are ultra sensitive to criticism. But I think it holds for many patients who are not necessarily, given this disorder. So the question is, what triggers it? Now, the thing I don't like about the analytic thing is that it implies that what triggers it is an unresolved conflict on the part of the therapist. And that may or may not be the case, because if you're working with a patient who is really abusing his partner or his children, then I don't know that necessarily means that the therapist has unresolved conflicts about that. What's your sense of what can trigger?
Yeah, I think that the perfect analytic patient is someone who doesn't need analysis. And the therapists are often most comfortable with people most like them, well-meaning, smart, interested in change, self-aware. And the frustrations, I think, happen most often with the more difficult patients. That the less like the patient is to the therapist, the less likely the patient is to want to participate in a shared exploration aimed at change. The more difficult the person is in their life with others, the more likely the therapist is to be frustrated by them. And that the ability to turn a difficult patient, someone you don't want to be in the room with, into an exciting and interesting patient, I think that that's what Marcia did. That the DBT was able, in her personality, her charismatic personality, was able to take the people who caused the most trouble to themselves and to other people, who were frustrating, and instead make them interesting and sympathetic.
What do you use the term difficult patient? And then that's a loaded word, because it sounds like it's blaming the patient for being difficult. So what is a difficult patient?
Well, I think let's start with what's an easy patient. An easy patient is someone who's doing very well in life, who has isolated problems that they're working hard on trying to change, who cares about other people and is doing their best under difficult circumstances. Someone we can easily identify with. Difficult patient, people who have more severe psychiatric symptoms, who are in relationships often unstable and irresponsible and impulsive and sometimes harming, who are self-punitive. And when you give a great interpretation, instead of the patient saying, aha, now I really understand myself, the person often gets worse and may, in behavior within the session or outside the session, do things that are going to be even more harmful to themselves or others. People who cause great trouble to themselves and to other people, and who have severe psychiatric symptoms, are more difficult to work with.
So here's another word I don't like. I don't like countertransference. I don't like difficult.
Do you have a better one?
Because what that brings up for me is, this person difficult. How dare they?
Well,
I wish they weren't so difficult. I wish they were so much easier.
Yeah. Well, I think that's the point. That the for me at least, the best patients in my life, the ones who helped me grow the most and who I've come to care the most about, are the ones who I originally thought of as difficult, felt frustration towards, and wanted to get rid of.
Yeah.
And that over the course of time became the easiest, the best patients, because they traveled the longest road, showed the most courage, and changed the most. So that the patients I treasure the most when I think back on my career are often the ones I least wanted to treat at the very beginning. The ones who were hardest for me to be in the room with.
Right.
The ones who challenged the most.
Yeah. So there's the issue. In a nutshell, how did you shift from seeing them and having the emotions associated with that as difficult to feeling positive toward them?
Yeah, a lot of it had to do with supervision early on. I had a number of patients who I didn't want to treat in my early training.
Mm-hmm.
It's like it was painful to be in the room with them. I couldn't stand the silences, the angry looks, the fact that everything I said seemed to be stupid, the contempt, and it was really good supervisors who. Harold Searles put it this way: that you're not seeing the damsel in distress. You're just seeing the dragon in this person. You're not seeing the damsel in distress that the dragon is guarding. And somehow or other, through really good supervision, I was able to get over my own initial immature feelings.
Right.
And in understanding the person better and understanding myself better, get into a deep relationship with people who at the beginning I didn't want to be in the room with.
Fascinating. I agree with that 1,000%, if that's possible. I think that's the issue. I mean, we can stop this podcast right now, but let's unpack that, because I think we can talk about the specifics of that, because that advice is exactly what I've been doing with supervision myself. Never read Searles, but did read some literature about this, about the difficulty and why people are annoyed or frustrated with others. And the triggers in therapy is that the patient is having difficulty changing and not changing in the way that therapists would like to see them change. And as a matter of fact, there's been research on this. And the research shows that when the patient is not progressing, the therapist develops negative feelings, which they often don't identify. So that becomes very, very important to get them to identify. And maybe that's what good supervision's about. So here's my experience in supervision. See, I'm curious as to whether it may parallel what you've experienced, either as a supervisee or a supervisor. the supervisee comes in and says, yeah, I want to talk about Mrs. X. And what I hear is the tone of voice, kind of annoyed, somewhat complaining. It's not, I want to talk about Mrs. X because she's doing such a wonderful job. No, I want to talk about Mrs. X because I'm having difficulty. That's a flag for me, that the therapist has negative feelings toward most likely has negative feelings toward the therapist, but may not be aware of it. So my first job then is to increase awareness. So I'll say something like, okay, sure. She's kind of frustrating, huh? Yeah, she is frustrating. So then you can hear through the tone of voice of the supervisee a little bit more affect coming out of frustration. Frustration is good. Anger is bad, although we know that's on a continuum. And then you find out what it is. Well, I ask her to do X and she says she'll do it, and then she doesn't do it. She doesn't do it. And then it could be body language that goes along with it. Well, that makes it hard. It's very, very difficult for you. Yeah. So you feel frustrated, don't you? Tell me what it's like. And some of the signs are, well, I don't look forward to the sessions, if the supervisee will admit it, or if you're the person analyzing yourself, you've got to pay attention to this. I don't look forward to the sessions. I keep watching the clock, wondering when it's going to be over. Can't wait for it to be over. So there are all these little signs that tell you, pay attention to the feelings. Did any of that happen in your supervision?
Yeah, and I think there's a kind of parallel process. It's also been described in the literature that very often when the therapist is frustrated with the patient, the supervisor becomes frustrated with the therapist.
Yeah.
The therapist will reenact with the supervisor some of the things that he or she's experiencing with the patient. And you can actually feel in the room that if it's supposed to help rejecting, complaining patient, you'll often find the trainee being help rejecting with you.
Yeah.
The process is parallel, which gives you a tremendous amount of information. And I'd like to go back to get you to speak more about compassion. How does the frustration get converted into?
Yeah, we'll come to compassion because that's really important. I believe that. But the idea is to gradually get them to become aware. And that is, it's a process that the supervisee doesn't necessarily want to share with the supervisor. And, we want to come back to your point, which I think is an excellent point, but let's play it out with trying to change the supervisee, and then we can talk about what the supervisor can do. So the supervisee has to feel there's a safe situation in which to self-disclose and needs to feel validated. So the supervisor can self-disclose and say, yeah, I've had problems with patients like that. I know what it's like. It's very, very frustrating, and I sometimes, it may leak. And we talk about frustration leaking, and it can leak through facial expression, tone of voice. It certainly can leak through content and body language, the rest of the body. But I think the tone of voice and facial expression. You agree on that?
Of course, yeah, sure.
Yeah.
And you'll, I think, often again see the therapist in discussing it will often mirror a lot of the emotions that the patient's having. So you get into these reverberating cycles where the patient's very frustrated with himself or herself. And one of the things I've often said to trainees, if you think you're frustrated with her, imagine how she's feeling about herself or he's feeling about himself.
Mm-hmm. Or about you.
And about you, exactly.
Yeah.
Exactly right.
Sounds almost like a couple session.
Yeah. So how do we get to compassion from that, Marvin?
Well, let me just do the Sullivanian footnote, okay?
Go ahead.
People are simply more alike, more human than otherwise.
Yeah. Right.
So the therapist is just as human as the patient.
And I think that's the key to compassion. I think you've nailed it.
So what is compassion? I think it's more than just empathy. I think it's empathy plus. So let's talk about what empathy is. Did I tell you in a previous podcast my, I think I might have, my very low-tech view of compassion, of empathy as being a Rolodex in the therapist's head? No, that's very low-tech. So there's a Rolodex in our heads. And a patient says something and you want to understand what it was like for them emotionally, thinking and everything, and every other way. So you go through your Rolodex and you find a card where your experience, either in personal life or in your professional life, or maybe even reading the literature that is similar to that. And then you think, okay, what was that like? And then you use that to understand and reflect back and validate and empathize. This is where Marcia was so good, because she had lots of cards in her Rolodex that parallel the cards of her patients, and she could get there. But compassion's a little bit more. I think compassion is also tuning into the pain of the person. So the obnoxious person whose life is not working is obnoxious, and you could easily get very annoyed with them. But this is the only life they have. They're not going to go around another time. So they're going to spend their only lifetime in conflict and never have the joys and the closeness and the intimacy. Oh my God, isn't that terrible? That is terrible. This person is no longer obnoxious. This person's being deprived, and it's sad.
This person is not just a dragon, also a damsel in distress.
Yes, exactly. Exactly.
And I think that there's something, I mean, you're stating it in an appropriately poetic way, because when you get past the point of being frustrated and to the point, and frustrating each other, and to the point of having a deep and real relationship, there's something so special about that. It surpasses most of human relationships and experiences.
Yeah.
It's unusual in everyday life. The tendency is that if someone is that obnoxious to you, you avoid them and they avoid you.
Right.
In the therapy situation, you're forced to climb hills that normally you would avoid. You're
Yes.
forced to experience things in yourself that normally you would not want to experience.
Yes, like what we did in a previous podcast, Alan. You know, I'm at my best as a human being when I'm doing good therapy, at least, because you can be compassionate.
And it's precisely, I think, that the wonder of surmounting the original distrust, distaste, anger, fear, and achieving a relationship that will, for the patient, often be new and better than they've ever had before, and for you may, in some ways, be new and better than you've had before.
Right.
And the people, the therapists, and I think the majority of therapists do this, filter only toward the easy patients. I'll use the word easy. Avoid the people they wouldn't normally want to be socially friendly with in life.
Mm-hmm.
Avoid them in therapy relationships for the same reasons of having negative reactions. Those therapists never get to have that experience, and never grow and never become better therapists, because they they take the easy way out.
Yeah. And as you said a little bit earlier, this is your experience that you've had. The people who you dislike the most, who were quote difficult, eventually you saw the other side of them, and it was you that changed. But before we finish, and I appreciate the compliment of describing what I'm saying as poetic, but let me bring out the scientific part of me as well. Okay, which is not mutually exclusive.
Not at all.
You could think with both parts of your brain. So what is this all about? We blame people. We get annoyed at people, not for what they do, but because of what we think their motive is. The mom or father who gets angry and hits the child because the child is a brat and is being disobedient has an implicit belief that the motive is they're defying me. They don't like my authority, or they're challenging me. And the anger is directed toward the motive, not the behavior. So the classic example I've used many, many times is the person who's making a favorite dish for their partner, and is taking great care to set the table and do it just the way they want. And the partner is supposed to come home at 7, doesn't come home, doesn't call, 7:15, 7:30, 7:45. And here the person preparing the food is getting increasingly more angry. That son of a bitch. Here I'm doing all this so inconsiderate of him, her. I'm working so hard, and all she cares about is themselves. That's the motive that's perceived for not coming and not calling. The person comes in disheveled, clothes all messed up. I was in a car accident. My cell phone was broken. I couldn't speak. I was in the hospital. I'm okay now, but I totaled the car. Sorry about that. The anger gets transformed into compassion because there was a reattribution of the motive. Some people call it reframing, but more specifically, the reattribution of motive. There's been lots and lots of research on this, and it shows that it works. And clinically, we know that it works.
And it frees up empathy.
What's that kind of empathy?
It unlocks empathy.
That's poetic. Okay. Whether we're going to be poetic or scientific, the clinical observation and experience and the research data coincide here. So what's the solution? What does the therapist have to do? We can say this before we finish. And maybe at some future time we can talk about the supervisor. But what the therapist needs to do is first recognize that they're frustrated. By tuning in, by recognizing, I'm not looking forward to this, by thoughts that are occurring, and then to stop and do some self-therapy before the session. Why am I angry? I'm angry because I'm working so hard to do this therapy and this person's not changing. How dare they? I have better use for my time. And all the crazy stuff that is causing the therapist to be frustrated. They've got to own up to that. And then they've got to switch and say, well, what is this about? What's going on with the patient? Let me go to my Rolodex. Let me see if I can conjure up some compassion, empathy, and tuning into the unfortunate circumstance this person is.
One slight addition, and then a question and possible suggestion for a future podcast. The addition is it's not just before the session; it's every minute during the session
or during the session. Absolutely,
that's what therapy is all about.
Yes,
monitoring your reactions and trying to understand them better and relating to how much is this your craziness, how much is it the reaction.
But hopefully, at the very least, our podcast today can say something to supervisors. How can you get your supervisee to go from frustration to compassion?
And I think maybe in the next week, if you're willing, we could try to answer this question. Can you teach empathy?
Oh, that's a tough one. I'll have to give some thought to that.
Okay.
You wanted me to talk next week about the third wave in CBT. So I've been doing some note taking on that. So why don't you do some research on the topic of empathy? We can do that either next week or the week after.
Okay, very good.
Okay?
Have a good weekend, Martha.
Have your grandkids come yet?
Yes. Okay.
They've been very quiet. Tell them thank you for
I
being
will.
quiet, and now you can go from one thing to another.
Okay, be well, Marvin.
You too. Bye-bye.